A few technical housekeeping notes to cover. Listen using your computer speakers. Make sure they're switched on and the volume is high enough. Audience microphones and cameras have been disabled during the webinar. If you have any technical difficulties, please enter them in the Q&A panel and a technician will attempt to assist you. Questions are welcome throughout the webinar. Simply enter your questions in the Q&A panel found at the bottom of your Zoom webinar screen. Questions will be addressed near the end of the webinar. A recording of the webinar will later be uploaded to our Heart and Stroke YouTube channel and our Stroke Best Practices webinars webpage. Now let's begin with a land acknowledgement. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call these lands home. Hello, my name is Kelly Van Houten, and I'm happy to serve as your webinar moderator today. I'm a registered nurse by trade, and I work as Manager Heart at Heart and Stroke. This is where I facilitate the National CHD Strategy and Action Plan through partnership with organizations across the country. It is my pleasure now to introduce our panel, starting with our person with lived experience. Her name is Sophie Bessette. Sophie can be described as a true Swiss Army knife, leveraging a rich background in advertising agencies like Sid Lee, pioneering firms like Airbnb, and cutting-edge creative studios in the music industry like Silent Partners. Her skill set includes project management, operations, and production across various media, including video, photography, and events. Known for her persistent determination and vibrant positivity, Sophie embraces challenges and thrives on continuous growth outside of her comfort zone. Additionally, she currently sits on the advisory committee for the Heart and Stroke Foundation, where she works tirelessly to improve the quality of health services for Canadians impacted by heart defect conditions and their families. Off the clock, Sophie pours her energy into running, ski touring, surfing, and snowboarding. Welcome, Sophie.
Hi, welcome. Thank you.
Dr. Andrew Mackie is a pediatric cardiologist at the Stollery Children's Hospital in Edmonton and a professor of pediatrics at the University of Alberta. He did his cardiology fellowship at Boston Children's Hospital and completed a Master of Science in Epidemiology at the Harvard School of Public Health. His research is focused on improving the transition process from pediatric to adult care for adolescents and their parents living with congenital heart disease. He conducts clinical trials and observational studies in this field and was recently funded by the Heart and Stroke Foundation to lead a team focused on care transitions across the lifespan in CHD. Hello, Dr. Mackie.
Morning, Kelly. Thank you.
Barbara Bailey is a nurse practitioner, and she holds advanced knowledge in adult congenital heart disease, or ACHD, with a focus on postoperative management. Since April 2015, Barb is the NP for the Toronto ACHD program at the Peter Munk Cardiac Centre, which is part of the University Health Network. Barb is currently cross-appointed with the Lawrence S. Bloomberg Faculty of Nursing through the University of Toronto. She holds memberships with the Canadian Council of Cardiovascular Nurses, International Society of Adult Congenital Heart Disease, Registered Nurses Association of Ontario, and the Canadian Nurses Association. She is the current president of the Nurse Practitioners Association of Ontario. Barb is certified in cardiovascular nursing as well as basic and advanced cardiac life support. Her accomplishments include patient education initiatives, such as a children's storybook to help parents discuss their heart surgery with their children, and the development of mindfulness recovery program after cardiac surgery. She has co-authored publications in ACHD and cardiovascular surgery. Welcome, Barb.
Thank you so much for having me.
The disclosures of our panelists are listed here. Andrew has received grants for clinical trials from sources such as the Heart and Stroke Foundation and CIHR over the past 2 years. There are no other disclosures to announce. Now, here are today's learning objectives: to describe the key characteristics and common types of congenital heart disease, to discuss the lifespan approach to managing congenital heart disease, including key stages and considerations, to gain insight into recent research findings related to transitional care for individuals with congenital heart disease, and to reflect on the personal experiences of individuals living with congenital heart disease, enhancing understanding of the calls to action in improving care. I will now hand it over to Barb to get us started. Barb.
Thank you so much, Kelly, and thank you to all of you. I'm really excited to be here today and talk about one of my favorite things, congenital heart disease. So I got to have the privilege to talk to you about just to try to better understand, well, what is congenital heart disease? And when we hear about it, but do we really know about it? So what congenital heart disease is actually a structural heart problem and it's present at birth. It can be diagnosed at birth or pre-birth, or also it can be diagnosed later in life. Also, just to highlight that congenital heart disease increases the risk of heart and brain and cognitive issues, including anxiety and depression. And CHD more than doubles the risk of stroke and increases the risk of heart failure, vascular and cognitive impairment, and cardiac arrest. So really important for us to talk about this today. Next slide. Now I'm just going to walk through, I'm not going to go through all of the common sort of heart defects that everybody has, because I think I could basically spend the whole webinar on this. So what we thought, and I know that Heart and Stroke has put some resources into the chat for you to have a look at if you're curious about what I just spoke about. But basically here, this is a nice diagram just to emphasize what the normal heart looks like. And essentially you have two upper chambers of the heart. So I know this is a very busy slide, but I just want to highlight the upper chambers. There's an atrium on the left side and an atrium on the right side. And then you can see below that we have a left ventricle and a right ventricle. You'll notice that there's definitely the job of both the atrium and the ventricle have different jobs. For example, the ventricles are the pumping chambers of the heart. And on the left side in the normal heart, the left ventricle will pump blood through that big vessel to the aorta. So you're going to pump oxygenated blood, so that healthy, rich, oxygenated blood to the body through the aorta. And then the body uses that oxygen-rich blood and then feeds back to the right side, where it goes to the lungs to get oxygenated. So I think what's important with congenital heart disease is that there can be some structural defects. I'm just going to talk about 3 different defects. First is an atrial septal defect, and you may or may not be familiar with these terms. So just a friendly reminder that in the chat is the resources available. And essentially what an atrial septal defect is essentially where you have an opening from in the atria, right? So what I talked about, there's it's separated by a wall, and there's an opening, and you can have blood sort of moving from one side of the atria to the other side of the atria. So, just to highlight that they can be in different areas, right, of the atria. And so you can have in different locations. And also to highlight with an atrial septal defect is that they can be small or they can be big. And it really just depends. And there's different ways to treat it. So we treat here, we can treat it in the cath lab. So there's various devices that we may insert in the cath lab to close that defect, or you may actually require open heart surgery. And that's where you'll see me here after surgery, depending on the size of the defect. The next is a ventricular septal defect. And I think I highlighted what the ventricles are, which are just, again, the lower chambers of the heart. And you can sort of see that how thick that area is between the ventricles. And again, there'll be an abnormal opening in the ventricles to allow that blood to cross. And remember what I emphasized is you have oxygenated and deoxygenated blood. But if there's an opening between the two, the left and right, there's going to be a mixing of the blood. And then indeed, you can actually have low saturations. And the next defect I just wanted to highlight is called tetralogy of Fallot. And essentially, there's 4 defects that are associated with tetralogy of Fallot. It's the most common cyanotic heart defect. And again, just to emphasize that that mixing of blood from oxygenated to deoxygenated blood, you're going to have a deoxygenated state where people can have cyanosis. So those in general are 3. I could list, oh my goodness, hundreds. But just important, just to remind you or just to have a look at the heart and just that every feature of the heart has a different job. So the atrium is going to look and work differently than the ventricle. Next slide.
Over to
I'm
me.
going to hand over to Andrew. Sorry, Andrew.
That's okay. Thanks, Barb. And thanks, Kelly, to you and the Heart and Stroke team for having me. It's great to be here. Just a few quick facts about congenital heart disease. About 1 in 100 babies are born with a congenital heart defect, which makes defects of the heart more common than defects of any other organ system in newborns. Of those 1 in 100 babies, about 20 to 25% have what we call severe defects, by which mean they will require open heart surgery or other types of cardiac procedures, such as a cardiac catheterization in the first year of life. Some of these children will require multiple operations through childhood and will spend weeks, if not months, of their early years in hospital. However, the good news is that among all children with CHD at birth, more than 90% nowadays will survive to adulthood. And this is a success story that is a result of improvements in surgical care, anesthetic care, and cardiology care. And this slide represents work from the province of Quebec led by my colleague, Dr. Morelli at McGill University. And what it demonstrates is the number of individuals in Quebec living with congenital heart disease. On the left side, we have the year 2000, where approximately half of individuals with CHD were adults in red. You can see that the red line increases exponentially over time from 2000 to 2010. Whereas the blue line, representing the number of children, increases just slightly. And as a result, in 2010, 2/3 of individuals living in the province of Quebec with CHD were adults. We don't have more recent data, but you can imagine that this exponential curve is continuing to rise. Next slide, please. So this emphasizes the point that congenital heart disease is a lifelong condition. It may be diagnosed in the womb or in early infancy, or as Barb said, it can be diagnosed later in adolescence or even adulthood. But by definition, it's always present at birth. And for the vast majority of people with congenital heart defects, they aren't cured and therefore carry the condition with them throughout their life. And this means that healthcare providers like myself and Barb and others need to figure out how to facilitate transitions through important life stages for individuals living with congenital heart disease. Because those normal life stages, like growing up and becoming an adult or going through pregnancy, can be more complicated than for those who don't have congenital heart defects. And adult survivors need lifelong care. As Barb pointed out, new cardiac problems can develop in adulthood. These include, but are not limited to, heart failure, heart rhythm problems, stroke, so on and so forth. Other organs can also be affected by congenital heart disease. This includes, of course, the brain in the form of stroke, or the brain in terms of mental health conditions, which we know are more common in those with CHD. The kidney and liver can also be affected by individuals with certain types of CHD. And a warning, patients may not have symptoms in the early going when complications are arising. So the absence of symptoms doesn't mean that people living with CHD don't need to go to their doctor, because going to the cardiology clinic can allow early detection of new problems before symptoms begin. Repeat surgery or other procedures may be needed throughout adulthood for people with CHD. And unfortunately, some adults with complex CHD are at risk of premature death relative to the general population. Next slide, please. Now, when we think about adolescents graduating from the pediatric healthcare system at around the age of 17 or 18 in Canada and entering the adult healthcare system, we need to keep in mind that there are quite different models of care. There are some generalizations on this slide, but in general, the pediatric healthcare system is viewed by patients and their families as being holistic, nurturing, family-centered, and the pediatric programs in general have lower patient volumes and see fewer patients on any given day than our colleagues in the adult side. The adult system provides excellent quality of care, but the focus is different. It's a more autonomy-focused system rather than a family-focused system. And patients are expected to advocate for themselves, manage their own health in conjunction with their providers, of course, and make treatment decisions independently. And this can be quite challenging for young adults who have not necessarily developed the skills that they need to make decisions, particularly those who have some cognitive challenges or learning behaviors, learning difficulties, which are more common in the CHD population. And when young adults arrive in the healthcare system on the adult side, they sometimes perceive their providers as quite time-strapped and unavailable compared to what they've been used to on the pediatric side. So it can certainly be a bit of a shock. And this brings me to the topics of transition and transfer. So transition is a process. And when we talk about pediatric to adult transition, we're talking about something that is a purposeful and planned preparation of adolescents and young adults to enable them to succeed in the adult healthcare system. Transition, if done well, fosters developmentally appropriate acquisition of skills to manage their CHD. Transition is not a single event in time. It takes years to develop these skills. And this process spans both the pediatric and the adult healthcare systems. In other words, it isn't finished the day the young adult turns 18 or the day they arrive in the adult clinic for the first time. Transfer, on the other hand, is an event. And it's when the responsibility for care is handed over from the pediatric doctors and nurses to the adult CHD clinic. Next slide, please. And unfortunately, there are a number of consequences of transition and transfer. Beginning on the left, healthcare dropout is unfortunately still quite common among young adults with congenital heart disease. About 25% of Canadians with CHD experience lapses in care for more than 2 years between leaving the pediatric system and arriving in the adult system, and many are lost to follow-up for much longer than that. Among those who do arrive in the adult clinic, some have difficulty developing emotional attachments to their adult providers. We know that risk-taking behaviors, including poor treatment adherence, is quite common in young adults and adolescents. And this contributes to increased emergency room visits and increased hospitalizations, which are well documented in this age range. Next slide, please. So for all of these reasons, graduating from pediatric care as a young person with congenital heart disease and trying to span the divide or the chasm that is the bridge to adult care can seem risky and pretty scary. And with that in mind, I'd like to turn it over to Sophie. And Sophie, perhaps you could share some of your experiences and recollections of being a teen and a young adult with CHD, and just tell us a bit about what that was like for you.
Absolutely. So transitioning from pediatric to adult CHD was actually a very tough moment in my life. You know, as a child, I had like this structured medical routine, and my parents, like, they handled like everything. But suddenly as an adult, like, I'm expected to manage my own care, and no one really prepared me for that shift, you know. And for example, I didn't even realize until adulthood that I couldn't be cured and I would need to see a cardiologist like for the rest of my life. So I went from pediatric hospital, where I lived for the first 3 years of my life. Everybody at the hospital knew me and I knew everyone also. And I really felt like home, and I felt like I was a very safe place. And then I was transferred to this like adult like healthcare system, where I had to face like the real challenges of living with CHD. And at that time, there were no resources to guide me through like that transition. So looking back, like, and knowing what I know now, I'm so relieved to see how much things have and continue to evolve.
Thanks, Sophie. So looking back, how could the healthcare system have better supported you or prepared you for that move?
I think the healthcare system could make the transitions from pediatric to adult to CHD like smoother by making it like gradual, um, well planned, and also like to make it like a process instead of a sudden shift. And I believe also that teenagers, they need more education about their condition, the guidance on how to navigate the adult healthcare system, and maybe like a dedicated transition program that connects them with adult, so it's easier to do that shift.
Okay, thank you. So maybe we could have the next slide. And I'm just going to spend the next few minutes describing some of the transition research that I've had the good fortune of being part of, along with colleagues in different sites around the country. So first of all, about 15 years ago, I've had the opportunity to work with some terrific nurses here at the Stollery Children's Hospital in Edmonton. And together we established a teaching program for adolescents that happened during clinic visits to the cardiology clinic. And currently we started around 13 to 14 years of age, although 15 years ago we had to start with older teens and 16 and 17-year-olds, and then work our way down to younger ones. And this program involves one-on-one teaching sessions between the nurse and the teen at each visit. And topics include reviewing their CHD anatomy with the assistance of diagrams and heart models, reviewing prior surgeries and cardiac catheterizations that they've had, and explaining again with the diagrams what those surgeries and catheterizations did. And then this ties into a discussion about potential late problems or complications that could happen with the heart in the future. And this sends across to the message to the teen that they're not cured, and that CHD is a lifelong condition, and that follow-up throughout adulthood will be very, very important. Follow-up in a clinic where there are specialists trained in adult congenital heart disease. These teaching sessions also involve some risk-taking behaviors. Could you just go back to the previous slide for just a second? Some risk-taking behaviors that adolescents are known to participate in, and how that might affect the heart. So alcohol and cannabis and contraception and sex. And they're also provided the contact names and location of the adult clinic, because one thing that teens fear is not really knowing where to go for their first appointment. So we have the nurses literally take the teen to the adult clinic which we can easily do because they're just a few minutes walk, so that they know where they're going to go for their next appointment. Next slide, please. Then more recently, I've worked with colleagues from McMaster University and McGill University to develop an app for transition age youth. And we call this the MyReady CHD Transition app. It was originally an app that was built for young people with brain-based disabilities like cerebral palsy and seizure disorders. And we modified the content to make it appropriate for congenital heart disease. And we tried to fit as much of the content of the nurse-based teaching into the app. And the rationale for the app is that, first of all, about 95% of Canadian teens walk around with a cell phone at all times when they're out of their home. And secondly, having information about transition in an app makes it a bit more accessible to teens because they can look at the information wherever they want. And particularly for those who live far away from children's hospitals and have challenges getting to children's hospitals for appointments, this makes the information a bit more available to them. And on this slide, we have an example of a video of a young man who has CHD. And there are a number of videos in the app, about 30 to 45 seconds in duration. And in these videos, the young adults speak about their experience of arriving in the adult healthcare system, and they provide advice to those who are using the app. And on the bottom right, we see an example of a definition. There's lots of information in the app, but there's also fun stuff. There's videos and games and a virtual mentor that the participant can customize, and the mentor navigates them through the app. And we're currently studying this app and comparing it to nurse-led in-person teaching at 4 children's hospitals around the country: Stollery, Sick Kids, BC Children's, and St. Justine. Next slide, please. And there are 20 modules in the app, divided among 5 chapters. And the modules include developing a My Health Passport, which is a place where they can summarize the key pieces of information they need about their CHD, and they can store that information on their phone. And there are other modules that take on self-management skills, like how to manage medications and symptoms, how to make appointments, decision-making 101, and one that I really like, coaching parents to listen. Isn't that a great idea? Next slide, please. Another area of research that I've had the opportunity to lead here in the province of Alberta is a social worker for transition age youth. And we have recently wrapped up the Transition Navigator trial, which we call TNT for short, which is held across Alberta. We enrolled 335 participants aged 16 to 21, and half of the participants had the opportunity to work with a social worker for 12 to 24 months. Some of the results of this work are still being prepared for publication, but in general, the feedback about the Navigator from participants was extremely positive. The themes that arose from our qualitative research demonstrated, first of all, the theme of emotional support, the idea that the Navigator was always there for me, could always be contacted, and could always be a source of help. The Navigator, of course, was a source of navigational support. And one quote, they simplified the complex adult system for me. The Navigator also took on a whole person approach. They helped not only with the healthcare issues, but also with school, employment, and housing needs in some cases of these participants. And they were really viewed as a coach. And we have now hired a full-time social worker who spans the pediatric age range and the adult age range, again, 16 to 21-year-olds, and she's full-time at the Stollery now as a result of this work. Next slide, please. And then a couple of studies that I'm really looking forward to. A peer mentorship program has been developed and led by my colleagues at Sick Kids, and it's called iPeer2Peer. And the rationale for this is that peer support for adolescents and young adults has been shown to reduce feelings of isolation and provide emotional support and advice. And the way this program works is it includes virtual meetings between a mentee, who's an adolescent, an older adolescent, and a mentor who's typically 3 to 5 years older and has arrived in the adult system already. And the SIGKIDS team has demonstrated that this peer support is very effective in young people with other chronic health conditions that they studied, including juvenile arthritis and chronic pain. And there's an upcoming study in congenital heart disease being led by my colleagues, Dr. Samantha Anthony and Tegan Kalaki. And this will be conducted at 4 children's hospitals around the country starting soon. Next slide, please. That is a summary of the research that I've had the opportunity to be part of with respect to pediatric to adult transition. And today we're talking about CHD across the lifespan. So another important transition is the process of going through pregnancy and becoming a parent for adults with congenital heart disease. And Sophie, I know that you've had a pregnancy. In fact, I've had the good fortune of meeting your beautiful daughter. So perhaps you could share with us some of your thoughts, recollections, perspectives about going through pregnancy from the perspective of living with CHD.
So yeah, pregnancy was another major transition, and it came with a lot of stress. When my boyfriend and I decided to have a kid, then I underwent like a lot of tests just to make sure that my heart was strong enough to carry the weight of the baby. And thankfully, because I was super active already, the doctors had no concern about me being pregnant. You know, like they say that pregnancy feels like you're running a marathon for like 9 months, because it's a lot of work and it's difficult for the body. But I feel like for someone with CHD, it's more like running a sprint for 9 months. So I feel it's really difficult, like on the energy level and the heart and everything. But I was grateful to be like active, to have been active beforehand, because I think it helped me through that pregnancy. It was also very important for me to stay active throughout like that pregnancy. And so everything was going super well. And then at my 20-week ultrasound, we found out that my baby had a CHD as well. I can barely remember what the doctor said, because I was such in complete shock. They were saying that the chances of passing on this CHD to my kid was like so weak that I should not even like think about it. But it's like the fear and the stress of realizing that my baby wasn't healthy. It was like so like overwhelming. And I think like the hardest part was like the guilt. I felt like responsible for like passing on my heart condition to my child. So after that, the doctor started like running like every possible test just to make sure that my daughter's condition was not linked to any other illnesses. And all the focus was on the baby, and I was also focusing on the baby as well. But I was consumed by worry, and my boyfriend and I would like, we felt like we went through this like all alone. Like everybody's thinking about the baby, but I felt like no one was, thinking about me, even not myself. I was just like so so focused on the baby. And looking back, like I should have like seek like for like maybe mental health support or something like that, because it was so difficult for my boyfriend and I to go like through this. And I wish that the doctor just reminded me that I also need to take care of myself during that pregnancy. But they were like resources like available during that time. And maybe I didn't know about them, but I know there's even more now. So to help like parents and families like to navigate like through this journey. So it's a good thing.
Thanks, Sophie, for sharing some of your story. And you illustrated that women with CHD are at higher risk than the general population of having a baby with CHD. So there's certainly the added risk to the fetus. But regardless of whether the baby has CHD, we know that women with CHD require expert cardiology care by an adult congenital heart disease specialist during pregnancy. And this is because there are important changes to the circulation that occur in a pregnant woman, and complications with the mother's CHD and the mother's heart are certainly more common during the pregnancy period. And some can develop severe complications during pregnancy. But unfortunately, in Canada, many women with CHD do not receive cardiology care during pregnancy. And this reflects challenges accessing healthcare in general in our country. Women with CHD also experience emotional challenges during pregnancy that are above and beyond the normal emotional experiences of women who don't have CHD. And studies have demonstrated that psychosocial support from healthcare providers to support women with CHD during pregnancy is generally viewed as inadequate. But I'm excited to say that another study coming down the pipe very soon and funded by the Heart and Stroke Foundation will be led by Dr. Sarah Blissett and Sam Su at Western University. And their studies have the following objectives. First, to identify risk factors for not seeing a cardiologist during pregnancy. Second, to identify the educational needs and the psychosocial needs or emotional needs during transition to pregnancy and parenthood for women with CHD. And third, to learn from the first two studies to design and evaluate a peer support program for pregnant women, not unlike the peer support program for pediatric to adult transition that I described a few minutes ago. This is going to be very important work that I think has a real potential to improve pregnancy care in this country. Next slide, please. And with this, I'd like to hand it back to Barb.
Thanks so much. Thanks, Andrew and Sophie. That was excellent. I have to say, Sophie, when you described what you went through, I guess in some ways you go through a bit of survival mode, and that's what we do to get through, a difficult situation. So really resonated with me. And thanks so much, Andrew, for sharing that. I think it's a perfect segue just to highlight our call to action. So I think Andrew and Sophie really described what we're calling for. We have, and Andrew really nicely highlighted the current research and some other research that our colleagues are going to be doing. Tegan Kalaki is here at UHN, the Peter Munk Cardiac Center. So happy to, I don't know, Tegan, if you're on this call, but really happy to have you as our nursing cardiovascular chair. I know that Andrew highlighted in terms of access to specialized care. So in Canada, we have 32 specialized care here at Toronto General. We have our adult congenital heart disease program. Young people transition from sick kids, and we need to ensure that we can provide access to our patients in these specialized environments. And that's, as Andrew had mentioned, pregnancy. We have an excellent pregnancy program here in Toronto, led by my esteemed cardiologist that I'm so proud to work with. And then transition. I know we've sort of touched on this throughout the whole talk, but we really need to ensure that to do our best as clinicians to ensure that transition is as seamless as possible. There's lots of efforts that everyone is taking. I have to say, and I will highlight this, that anybody that works in clinicians or people living with congenital heart disease have a passion for congenital heart disease and are committed to the success and to be there for people living with congenital heart disease, and that includes myself. I know Andrew touched on that peer mentorship It's so important for any person living with congenital heart disease to have that peer support, whether you're a young person or an older person like myself. We all know that we benefit from speaking to our peers and having that support, somebody who really understands what you're going through. It is extremely difficult to be a person living with congenital heart disease, and your entire life may indeed be interrupted, disruptive, and meaning that school, work, etc., right, can be disrupted. So I think it's really important, and that's why that access to care. And if you don't live close to these specialized centers, it's extremely difficult to come, to that specialized care environment. I have to say that things have shifted, with the pandemic, and now that we're, I think, as clinicians, getting more comfortable with providing virtual care. So I have to say that, it has been, quite liberating for patients living with congenital heart disease to be able to access that expert care. I mean, there are many times that we have to actually see people in person, but I have to say that that's really opened up opportunities for us to provide the care and provide that essential care. Because at the end of the day, people need to have that support. Also, they also need our support, but they need community support and resources. I think it was Andrew and Sophie really talked about the mental health support that people need. We're all, I think everybody's feeling the need, from the pandemic, but in particular, if you live with congenital heart disease, and Andrew highlighted that indeed people are at risk for anxiety and depression. It's well known in the evidence in congenital heart disease. And I think we need to make sure that we have that support available to our patients living with congenital heart disease. I know here at our program, we're lucky to have a mental health nurse practitioner. It is absolutely wonderful just to be able to provide that support to our patients. Next slide. So now I just wanted to highlight the strategic framework in congenital heart disease. Sophie's going to sort of dive into things in a bit more detail, but just you can see here the snapshot of how important. I hope that you've heard that importance of that specialized care that people living with congenital heart disease need, the evidence-based care, optimal transitions, integrated health systems. We really can't do this work alone, can we? We need each other. We need strong interdisciplinary teams, social workers, nurses, nurse practitioners, people with lived experience, our cardiologists, physiotherapists, mental health supports. I cannot emphasize the importance of the team-based approach to provide that sort of whole person care, which Sophie will talk about. On that note, Sophie, I'll pass the mic to you.
Thank you, Barb. Yeah, so in this framework, there are three initiatives that really resonated with my experience. So the first one is optimal transition that we spoke about, specialized care, and the whole person care. So to me, optimal transition means not feeling lost during the biggest shift in life, when I moved from pediatric to adult care, or when I navigated pregnancy with congenital heart disease. It's also when I transitioned to adult care, I had no guidance, no resources. I had no idea what to expect. And later during pregnancy, I faced overwhelming stress with no one. I felt like I had no one to turn to for reassurance. And I believe a well-planned transition with the right support could have made those moments less overwhelming and helped me get the care that I needed at the time. And then for specialized care, it to me means everyone, no matter where you live, your financial situation, should have access to the treatment that they need. I think about my parents who were driving me to the hospital back and forth. We lived an hour and a half from the hospital. And like I mentioned earlier, for the first 3 years of my life, actually, I needed to go to the hospital like every day. So they were driving me every day. And then they had to like work less in order to be able to take me to the hospital. So all this, it was just like a big challenge, like for my parents, for my family. And I feel like it's heartbreaking to know that some people they face like such barriers to get the care that they deserve. So to me, specialist care should be like inclusive and ensure that every people with CHD, regardless of their background, get the best possible like treatment that they need. And then whole care person is just to address that congenital heart disease is just not a medical condition. There's so many things that we need. It affects like every part of a person's life. Like growing up, I feel like I struggled with feeling different from other kids. I couldn't run as fast. I was avoiding certain activities, and I carried like a lot of like emotional weight, like from feeling like inadequate to worrying about my future, and so on. So as an adult, the mental load didn't go away. It was actually expanded when I had my daughter. So when I got pregnant, so the whole care person to me means like recognizing that we need more than just a treatment just for the heart. Like there's a whole like system that needs to be implemented to help us like thrive in their life, if I would say. So yeah, so that's about it for me. Thank you. I'll pass the mic to you, Kelly.
Thanks. Thank you, Barb and Sophie, as well as Dr. Mackie, for your insights into congenital heart disease, transitional care, and life with CHD. As we bring the webinar to a close, here are some key messages from our time together today. More people are surviving with CHD and living longer. People with CHD require care that evolves as their health changes over time, yet many face challenges accessing the support they need. Having CHD puts people at higher risk for other heart, brain, and cognitive issues. Everyone with CHD should have timely and equitable access to specialized diagnostics and interventions, including lifelong support to optimally manage their conditions. And lastly, in partnership with organizations across the country, Heart and Stroke is leading the development of a national strategy and action plan to improve systems of care and equity in access to care. Now I'm going to open up the space to our audience for some questions. And as we wait for a few more questions to come in from the audience, I'm going to start by asking the panelists a question that I have. So this question is for Sophie. Sophie, I am a mom of an 8-year-old girl. And as I listened to you speak, I really wondered, how has living with CHD influenced how you raise and support your daughter?
Good question. I think living with CHD taught me how important it is to focus on possibilities rather than limitations. When I was a kid, everybody was telling me that I couldn't do sport, like was refrained from any physical activity because it might like affect my heart. And I got so frustrated that I started like working out, and I was like, I want to have a better life, so I'm gonna just start and work out. And turns out that it was such a good thing for me. And from that day, I was like, okay, so this is how I want to live my life. I'm gaining back control of my life. So it opened a lot of like possibility. So I decided that I was gonna not only live my life thinking about possibilities, but also I'm teaching my daughter to do the same. So if I stayed in this restrictive like mindset, I feel like my health and my life would be so much like different today. So I encourage my daughter to be active, to be confident. And I tell her all the time that our scar is the proof that we have like superpowers. Like we battle like through life and we won. So there's nothing that can really stop us. So yeah, and I try to exactly to support her to have her have this like growth like mindset and this resilience and and if she wanted to do like she wanted to go to the Olympics, that I would be the first person like cheering up on her and be like, okay, let's go. So yeah, that's that's about it.
That's amazing, Sophie. You sound like your daughter's biggest fan and advocate, and it sounds like she's very lucky to have you, and you are very lucky to have her as well. So that's thank you for sharing that. I am going to pose a question from the audience to Barb. Barb, we have an audience member asking, they have had an aortic valve replacement. Is that considered to be CHD? Could you speak a little bit to the distinction?
Sure, I can. Yeah, nice. Thanks for the question. So it really basically, I'm not sure if you had a bicuspid aortic valve. I'm not sure if that's something that you were born with. So I think as Andrew and Sophie now highlighted, congenital heart disease means that you were born with the defect. And so you may indeed, if you had a bicuspid aortic valve, that you may have required a aortic valve replacement. Sometimes, and you know, you require aortic valve replacement because just as we age, and that means me too, that you know, in time, right, we may indeed, as we age, need aortic valve replacement. So I hope that answers your question. I just don't, without knowing the context of the background, but you know, happy to liaise with Kelly on the call to see if we can. And I think, and I can see that Kelly's just put up some of our resources here at Heart and Stroke, just to share with you. So thank you. And then a list of kind of some of the defects. So, but thanks for the question.
Thanks, Barb. So not a question, but a comment. I see that someone wrote they're a mom of a CHD patient and a volunteer with patient and family-centered care at the Stollery. Peer Support has recently started a program with Fetal Echo to support families who have just received a diagnosis. It states that they're passionate about the program and hoping it grows. So love the idea about peer support for teens transitioning as well, as they suspect that this will be very helpful for their daughter. So thank you for that comment and for that support. I think Andrew did a fantastic job in speaking to some of the work that's happening there as well. And I also just wanted to share that as it relates to the National Strategy and Action Plan, Heart and Stroke is working with our partner organizations, and we're on a trajectory to 2030. So we are investing the time, we are investing the energy and the focus on CHD care. And so the goal is to strike a sustainable model for the strategy in Canada for CHD. So thank you for that question as well. And I just wanted to really thank our audience and the panelists for the engaging discussion. You know, at this time, we are sharing some helpful resources to support your continued exploration of CHD. And just for your reference, we have provided resources from Heart and Stroke as well as external resources. They're shared in the chat. We have also listed some other important groups working in the CHD space, and we encourage you to check out their work as well. And just so you know, in the next week, the webinar will be available to view and share on our YouTube channel and the Stroke Best Practices website as well. And so here we want to thank everyone for sharing in the passion and knowledge to raise awareness about congenital heart disease, both during this webinar and beyond. So thank you so much to our panelists for their time today, and a special thank you to Sophie for such an intimate conversation about what your experience has been living with CHD, what you've experienced, and also what you've seen change, and your inspirational hope for how living with CHD will impact others in the future. So thank you so much to the panel.
Thank you. It was a pleasure to be on this panel.
Thank you so much.
Kelly, lots of great comments and questions coming through the Q&A there.
Is there one other one that you'd like to answer, Andrew?
Oh, well, I'd like to answer all of them, but I only have 4 minutes, and I'm not necessarily qualified to answer all of them. But so there's a comment from Aaron. What support systems, government heart and stroke programs are available for people with CHD to help find jobs and work? So as a pediatric cardiologist, most of my patients aren't old enough to work, but if Aaron, if you're in the 16 to 21-year-old age range, then the social worker transition navigator we have here in Edmonton and also in Calgary takes really a whole person approach, and that includes connecting participants in that program with employment opportunities. Barb, I don't know if there's anything else that you can add from an adult provider perspective.
Yeah, thanks so much. I mean, we do have a social worker that we can connect to, but I think that's probably something that we can sort of improve on in terms of support and resources. But happy to speak offline. Like after this, I'm here and able to sort of help answer those questions.
And then there's a comment from Christy Wolf. Christy, great to see you here at this webinar. Christy says, I'm interested to know how families who are not directly connected to the hospital sites you've been mentioning can advocate for transition supports across other sites. So if you and your child are managed at a different children's hospital other than the ones that have been mentioned in today's program, I think that you should ask your child's cardiologist what transition supports are in place for teens and young adults at your site. So I would encourage you to advocate for that. And here at the Stollery, we regularly field questions from parents and families who live a little bit further away from Edmonton and can benefit from our support as well. So if you're not getting the sort of support you need locally, feel free to reach out to us in Edmonton.
And Andrew, could you speak to how someone can access peer-to-peer care? Is there a specific resource?
So outside of the research setting, I would encourage people to look at the Canadian Congenital Heart Alliance website. And that is one of the websites listed on the resources page, cchaforlife.org. And you may, I don't remember absolutely with certainty off the top of my head if they have a peer support program. Another source of peer support is the Adult Congenital Heart Association, or ACHA, which is based in the United States. And then, I talked about, we talked about peer support for transition age youth and for women who are going through pregnancy, but those are really in the context of research programs, and they have very specific inclusion criteria and specific age ranges. But I would begin with the Canadian Congenital Heart Alliance and inquiring there.
That's great. Thank you. And I just wanted to mention that the webinar evaluation will be coming to you via email. And the certificate of participation would follow the completion of the evaluation. So we really do appreciate your feedback on the webinar, and we wish you a very lovely rest of your day. Thank you so much.